At 12:11 p.m. on June 25, 2009, paramedics arrived at a rented mansion on North Carrollwood Drive in Los Angeles and found a 50-year-old man in cardiac arrest. By the time he was pronounced dead at UCLA Medical Center less than 2 hours later, the world had already begun reacting to news that would dominate global headlines for weeks. But the actual sequence of events that led to that moment and the specific way his body had been failing in the months and years before, it remained far less understood than most people realize, even now, more than 15 years later. This is not a story about rumors or speculation. This is a story built from the official autopsy report from the criminal trial testimony of the physician who was with him in his final hours, and from the medical literature on the specific substances found in his system. What actually happened to Michael Jackson's body in his final hours and in the years leading up to them is more medically significant and more genuinely tragic than the tabloid version that dominated coverage at the time. Michael Jackson had been preparing for what was being billed as his return to the global stage. A 50-date concert residency in London titled This Is It, scheduled to begin in July 2009. Rehearsals had been underway for weeks at the Staples Center in Los Angeles. The physical demands of those rehearsals on a 50-year-old body that had spent decades absorbing the cumulative stress of one of the most demanding performance careers in entertainment history were substantial. And understanding what those decades had done to his body is the necessary starting point for understanding what happened in his final hours. Michael Jackson had been a professional performer since early childhood. He began performing publicly before the age of 6. By the time he died, he had spent approximately 44 years as a working professional dancer and performer. The cumulative physical toll of that career on a human body is something that sports medicine researchers who study long-term athletic careers have documented extensively in other contexts, and the same biomechanical principles apply directly to a career built around the kind of high-impact dance movements that defined Jackson's performance style. His specific dance vocabulary included repeated high-impact landings from jumps, repeated rapid directional changes, and the specific biomechanical stress of moves like the moonwalk, which, despite appearing smooth and effortless, actually requires sustained muscular tension and places significant cumulative stress on the hip and knee joints through the specific gliding mechanism involved. Over 4 decades of professional performance, these movements performed thousands of times across hundreds of concerts and countless rehearsal sessions produce the kind of cumulative joint and connective tissue stress that orthopedic researchers associate with chronic pain conditions in aging performers and athletes. Michael Jackson had documented chronic pain dating back to at least 1984, when he suffered second and third degree burns to his scalp during the filming of a Pepsi commercial when pyrotechnics ignited his hair. The injury required multiple surgical procedures over subsequent years, and there is documented evidence that pain management following this injury was part of what introduced him to prescription pain medication use that would continue in various forms for the remainder of his life. He also suffered a documented spinal injury and underwent multiple surgical procedures related to his back and his vertebrae over the years, including procedures connected to performance-related injuries sustained during tours. The 1993 Dangerous Tour, the 1997 History Tour, and various other performance commitments all generated documented medical interventions for pain related to the physical demands his body was absorbing. By the time he began preparing for the This Is It residency in early 2009, Michael Jackson was managing what trial testimony later established was chronic and severe insomnia. This detail matters enormously to understanding what happened in his final hours, because the insomnia and the method ultimately used to address it formed the direct causal chain that ended his life. Dr. Conrad Murray, a cardiologist who had been hired as Jackson's personal physician, specifically for the duration of the This Is It rehearsal period and tour, testified extensively about the nature of Jackson's sleep difficulties during the criminal trial that followed Jackson's death. According to Murray's testimony, Jackson had been struggling with insomnia for an extended period and had developed what Murray described as a dependence on receiving propofol as a sleep aid through intravenous administration. This is the central medical fact that needs to be understood clearly because it represents one of the most significant departures from standard medical practice documented in the entire case. Propofol is a powerful general anesthetic. It is not designed sleep medication. It is not approved for use as a sleep aid in any clinical guideline anywhere in the world. It is specifically formulated for use in controlled surgical and medical settings where a patient's vital signs, including heart rate, blood pressure, and respiratory function, are continuously monitored by trained medical personnel using specialized monitoring equipment, because propofol induces a state that is not natural sleep, but rather a medically induced loss of consciousness that carries inherent and significant risks to breathing and cardiovascular function. The pharmacology here is worth understanding in detail because it explains exactly why what happened in Jackson's final hours was so dangerous and ultimately fatal. Propofol works primarily by enhancing the activity of gamma-aminobutyric acid receptors in the brain. GABA is the primary inhibitory neurotransmitter in the central nervous system. meaning its job is to reduce neural activity. By enhancing GABA receptor function, propofol produces a rapid and profound suppression of central nervous system activity. This is precisely why it is so effective as an anesthetic agent. It works quickly and it works completely. But that same mechanism that makes it effective for inducing surgical anesthesia is what makes it so dangerous outside a controlled medical environment. The suppression of central nervous system activity does not selectively target only the parts of the brain responsible for consciousness. It also suppresses the brainstem regions responsible for regulating breathing and cardiovascular function. In a surgical setting, this is managed through mechanical ventilation and continuous monitoring by an anesthesiologist whose entire job during the procedure is to manage exactly this risk in real time. There was no anesthesiologist managing Michael Jackson's propofol administration in his bedroom on June 25, 2009. There was no mechanical ventilator. There was no continuous electronic monitoring of his oxygen saturation or his cardiac rhythm in the way that would be standard in any operating room anywhere in the world. According to Dr. Murray's trial testimony, he had been administering propofol to Jackson nightly for approximately 2 months, leading up to his death, typically through an intravenous drip in Jackson's bedroom. Murray testified that on the night of June 24th into the morning of June 25th, he administered several sedatives, first attempting to help Jackson sleep through other means, before ultimately administering propofol when those other approaches failed to produce sleep. The toxicology report from Jackson's autopsy, which was conducted by the Los Angeles County Coroner's Office, documented multiple substances in his system at the time of death. The propofol concentration found in his blood was consistent with what would be expected from anesthetic dosing, rather than any approved sedative dosing range. Additionally, the toxicology screen identified several benzodiazepine class medications in his system, including lorazepam, midazolam, and diazepam. This combination is medically significant in a way that goes beyond simply identifying multiple substances. Benzodiazepines work through a related but distinct mechanism, also involving GABA receptor enhancement. When benzodiazepines and propofol are administered together, their respiratory depressant effects do not simply add together. They potentiate each other, meaning the combined suppressive effect on breathing and cardiovascular function is greater than what would be predicted from simply adding the individual effects of each substance. This synergistic interaction between sedative-class drugs is well documented in anesthesiology literature, and is precisely why combining these medication classes without intensive monitoring is considered extremely dangerous in any clinical context. Dr. Murray's trial testimony described the sequence of events on the morning Jackson died. After administering propofol and observing Jackson finally fall asleep, Murray testified that he left the room briefly. The precise timeline of how long he was away from Jackson's bedside and what monitoring, if any, was occurring during that period became a central point of contention during the criminal trial. What is documented is that at some point, Murray found Jackson not breathing. He testified that he began performing chest compressions, though notably on the bed, rather than on a hard surface, which medical experts testified during the trial would significantly reduce the effectiveness of CPR, since proper chest compressions require a firm surface to generate adequate compression depth against the chest wall to circulate blood effectively. The 911 call was made at 12:21 p.m. Paramedics arrived shortly after and continued resuscitation efforts. Jackson was transported to UCLA Medical Center where, despite continued resuscitation attempts, he was pronounced dead at 2:26 p.m. The official cause of death, as documented in the autopsy report, was acute propofol intoxication with the contributing effect of benzodiazepines. The manner of death was classified as homicide, which in forensic pathology terminology does not necessarily imply criminal intent, but rather indicates that death resulted from the actions of another person rather than from natural causes, accident, or suicide. Dr. Conrad Murray was subsequently charged with involuntary manslaughter, tried and convicted in November 2011. The prosecution's case centered on the argument that Murray's administration of propofol outside any appropriate clinical setting, combined with what the prosecution characterized as inadequate monitoring during the period when Jackson was sedated, constituted a gross deviation from the standard of medical care that any reasonable physician would have provided. Murray served time in county jail following his conviction and subsequently had his medical license revoked. But beyond the legal proceedings and the specific question of medical negligence, there's a deeper biological story here about what was happening in Michael Jackson's body during this period that deserves examination because it explains why a 50-year-old man's heart and respiratory system were vulnerable enough to fail so quickly once the propofol and benzodiazepine combination suppressed his central nervous system function. The autopsy documented that Michael Jackson was significantly underweight at the time of his death. His body mass index was documented as being below the healthy range. This matters physiologically because adequate body fat and muscle mass serve as a buffer against certain pharmacological stresses, and a body operating with minimal reserves has less capacity to compensate when vital functions like breathing and heart rate are pharmacologically suppressed. Trial testimony and subsequent medical analysis also established that Jackson had not been eating adequately in the period leading up to his death, likely related to a combination of the physical and psychological stress of preparing for the demanding "This Is It" tour and the documented insomnia that had been disrupting his normal sleep and likely his appetite regulation as well. Sleep deprivation itself has well-documented effects on cardiovascular function, including effects on heart rate variability and blood pressure regulation that would have compounded the vulnerability created by his nutritional status. The combination of chronic sleep deprivation, inadequate nutrition, the cumulative physical stress of decades of demanding performance work, and the specific pharmacological vulnerability created by combining propofol with multiple benzodiazepine medications created a biological situation where his body had essentially no reserve capacity left to compensate when his breathing was suppressed during the final administration of propofol on the morning of June 25th. There is also a specific pharmacological detail about propofol that is relevant to understanding why monitoring is so critical and why its absence in Jackson's case was so significant. Propofol has what pharmacologists describe as a relatively narrow therapeutic window combined with a complex dose-response relationship that varies significantly based on individual factors, including body composition, liver and kidney function, and concurrent use of other central nervous system depressant medications. This means the dose required to produce a desired effect, such as sleep, can be remarkably close to the dose that produces dangerous respiratory suppression, and that this margin can narrow further when other sedating medications are present in the system simultaneously. In a hospital operating room, setting this narrow margin is managed through continuous monitoring and the presence of trained personnel who can intervene immediately if respiratory function begins to deteriorate. The entire safety architecture around propofol use in legitimate medical practice exists specifically because the substance is recognized as having this dangerous characteristic. What happened in Michael Jackson's bedroom represents the complete absence of that safety architecture being applied to a substance that specifically requires it. There is additional medical significance in understanding the May 2009 period in the weeks before Jackson's death, according to multiple individuals who worked with him during This Is It rehearsals. Including the show's director, Jackson appeared notably thin and at times physically fragile during certain rehearsal sessions in the weeks before his death. This observation aligns with the documented underweight status found in the autopsy and suggests that whatever combination of physical and psychological factors was affecting his health was a progressive condition that had been building for some time, rather than something that emerged suddenly. The forensic toxicology in this case also identified lidocaine in Jackson's system at the time of his death. Lidocaine is sometimes administered alongside propofol because the injection of propofol itself can cause a burning sensation, and lidocaine is used to reduce this discomfort. Its presence in the toxicology screen is consistent with Dr. Murray's testimony about the manner in which the propofol was being administered and provides additional forensic confirmation of the medical procedure that was being conducted in a residential bedroom without the equipment or personnel that any hospital would require for the same procedure. The specific quantities of propofol identified in Jackson's system were notable to the forensic pathologists who conducted the autopsy. The blood concentration was consistent with what would typically be expected during active surgical anesthesia, rather than the kind of dosing that might theoretically be used for sedation purposes. This finding was significant during the criminal trial because it spoke to the question of how much propofol had actually been administered and whether the dose itself, independent of the monitoring failures, was inherently dangerous given the setting in which it was being used. Medical experts who testified during the Conrad Murray trial were unanimous in their assessment that propofol should never be administered outside a hospital or surgical center, setting specifically because of the respiratory depression risk and the need for immediate intervention capability if breathing becomes compromised. Several testified that the standard of care for propofol administration anywhere requires continuous monitoring equipment, specifically pulse oximetry to track blood oxygen saturation, and ideally capnography to monitor exhaled carbon dioxide levels, which provides earlier warning of respiratory compromise than oxygen saturation monitoring alone. None of this equipment was present in Michael Jackson's bedroom on June 25, 2009. The broader medical context here connects to a pattern that addiction medicine researchers have documented in cases involving celebrities and high-profile individuals who develop dependencies on medications administered by physicians who have financial or professional incentives that may compromise their clinical judgment. Dr. Murray was being paid a substantial monthly salary specifically to serve as Jackson's personal physician during the tour preparation period, and this financial relationship became a significant point of discussion during the trial regarding whether it created pressure that influenced his willingness to provide propofol despite the inherent dangers of doing so outside appropriate medical settings. The question of how Michael Jackson developed what Dr. Murray characterized as a dependence on propofol for sleep in the first place is itself medically significant. Propofol does produce a form of physiological adaptation with repeated use, though the mechanism differs somewhat from the dependence patterns seen with more conventional sleep medications. Tolerance can develop, requiring increasing doses to achieve the same sedating effect. And there is documented evidence in addiction medicine literature of psychological dependence developing in patients who have experienced propofol-induced unconsciousness, repeatedly, particularly in contexts of significant underlying stress or sleep disorders, where the rapid and complete unconsciousness produced by propofol may feel qualitatively different and more effective than natural sleep or conventional sedatives. This pattern, combined with the extraordinary pressure Jackson was under, preparing for what was being positioned as a major career comeback at 50 years old, following years of diminished public performance activity and significant financial pressures related to debt and the need for the tour to be successful, created the kind of circumstances where the medical decision-making that should have prevented this outcome was instead compromised by a combination of factors extending well beyond simple medical negligence. The final hours timeline, as established through trial testimony, phone records, and forensic evidence, paints a picture of a physician managing a patient using a medical intervention completely inappropriate for the setting, while the patient's body was already compromised by chronic sleep deprivation, inadequate nutrition, and the cumulative physical toll of 4 decades of demanding professional performance. When the propofol was administered on the final occasion, combined with the benzodiazepines already present in his system, from earlier in the night, his body's capacity to maintain adequate breathing was overwhelmed. Without continuous monitoring to detect the earliest signs of respiratory compromise, and without the immediate availability of resuscitation equipment and personnel, that any hospital setting would provide the window during which intervention could have prevented his death passed before anyone recognized what was happening. By the time Dr. Murray discovered Jackson was not breathing, significant time appears to have already passed, based on physical evidence, including his body temperature and the state of rigor mortis, assessed by paramedics and subsequently by the coroner. This delay meant that even once resuscitation efforts began, including the chest compressions performed on an inappropriate surface, that medical experts testified would have significantly reduced their effectiveness. The brain had likely already been deprived of adequate oxygen for a period sufficient to cause irreversible damage, even if circulation had been successfully restored. The full medical picture that emerges from the autopsy, the toxicology report, and the extensive trial testimony is not simply a story about an overdose. It is a story about a body that had been pushed to the edge of its physiological reserves through chronic sleep deprivation, inadequate nutrition, and decades of cumulative physical stress, finally encountering a pharmacological intervention, specifically propofol, combined with multiple benzodiazepines that required medical monitoring infrastructure that simply was not present. Michael Jackson did not die from a single mistake. He died from the convergence of multiple factors, each of which independently increased his vulnerability, and which together created a situation where his body's margin for error had been reduced to essentially nothing. The scientific and medical literature that has examined this case in the years since has used it as a significant case study in anesthesiology and pharmacology education, specifically regarding the dangers of propofol use outside controlled clinical settings. The case is frequently referenced in medical literature and continuing education materials for anesthesiology and critical care medicine as an illustration of exactly why the standard of care requirements around this medication exist and what can happen when they are not followed. What his final hours actually reveal when examined through the complete medical and forensic record is not a mystery in the sense of unknown causation. The cause of death is clearly documented and was established through rigorous forensic investigation and confirmed through criminal trial proceedings that examined the evidence in exhaustive detail. The mystery, if it can be called that, lies in understanding the full convergence of physiological vulnerability, medical circumstance, and human decision-making that led a 50-year-old man whose body had carried him through 4 decades of extraordinary performance demands to a place where a medication never intended for use outside an operating room became the final and fatal factor in a body that had simply run out of reserve capacity to absorb one more significant physiological stress. His body had been telling the story of decades of accumulated demand long before that final morning. The chronic pain, the sleep deprivation, the nutritional deficits, the pharmacological dependencies that had developed in response to genuine and severe insomnia that conventional treatment approaches had apparently failed to resolve. Every piece of that biological history converged in his bedroom on North Carrollwood Drive in the early hours of June 25, 2009. The complete medical record does not describe a simple story. It describes a body under sustained and significant stress finally encountering a specific and well-documented pharmacological danger without the safety infrastructure that should have been present and that any hospital in the world would have required as an absolute minimum standard for the procedure being performed. That is what actually happened in those final hours. Not rumor, not speculation. The documented medical and forensic record of exactly what his body experienced in the time before it finally could not continue